Hello, and thank you for joining the Systems for Action Research and Progress webinar. My name is Chris Lytle. I'm Deputy Director of Systems for Action. And for folks who are unfamiliar with Systems for Action, we're a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. We support studies across the country, testing tools and models to facilitate multi-sector collaboration across medical, social, and public health systems with the goal of improving population health and advancing health equity. Today, we're joined by Alicia Bunger, Dr. Alicia Bunger. Alicia leads a research team at Ohio State University, examining the use of regional governing boards to align services for rural children of the opioid crisis, and will walk us through the progress of the study. This research team was part of our third cohort of grantees and launched May 2019 and should be wrapping up in 2021. Now, if we can go back to the agenda really quickly, we'll have a brief presentation from Alicia and Dr. Amanda Girth, followed up by commentary from Jennifer Millisor. And if you have questions, we'll save some time at the end, so you'll be able to enter those questions in the Q&A box at the bottom of your screen throughout the discussion, and then we'll have our presenters answer at the end. So with that, I'll go ahead and introduce our presenters. Dr. Alicia Bunger is an associate professor in the College of Social Work at the Ohio State University. And Amanda M. Girth is Associate Professor of Public Affairs, Director of Washington Studies, and an Arson Fellow at the John Glenn College of Public Affairs at the Ohio State University. Jennifer Millisor joined Public Children's Services Association of Ohio back in October 2019 as the Ohio START Program Manager for Technical Assistance. And with that, I will pass the controls over to our presenters for the day.
All right, can you hear me now?
Yes.
Awesome, okay. Thank you. All right, so good morning, everybody, and thanks so much for the opportunity to share a little more about what we are learning through our S for A studies. And you'll get to hear from Dr. Amanda Girth and Jennifer Millisor here today. And we are part of a larger team based here in Ohio that spans multiple disciplines and includes partners from the child welfare system, our partners like Jennifer from the Public Children's Services Association, partners from the behavioral health system, including Teresa Lample from the Ohio Council of Behavioral Health and Family Service Providers, and stakeholders from another element of our behavioral health system. We have a bunch of regional boards that do a lot of service planning, and Sherry Walter and Courtney Ebersole from the Ohio Association of County Behavioral Health Authorities are also partnering with us on this project. And so we're excited to share what we've been learning so far. Our S for A project is intended to focus on the role and the impact of public behavioral health boards on aligning child welfare and substance use treatment systems for program implementation. And our study is anchored within the larger Ohio START initiative. And we'll hear in a second from Jennifer a little bit more about the START model and the Ohio START initiative. But our questions are really motivated by these driving public health and social justice issues. So Ohio is unfortunately first in the nation for some of the wrong reasons. We've been very hard hit by the opioid crisis, and being number one in terms of absolute numbers of heroin and synthetic opioid related deaths. and having a really high overdose death rate. And several years ago, sort of at the height of this crisis, on the child welfare side, we saw rising numbers of kids entering the foster care system because of caregiver substance misuse. And a large number of these cases were also connected with opioid use. We know from the literature that in the child welfare system, when caregivers come in because of substance use issues, their treatment needs often go unmet despite being connected to the system. And there's a high likelihood that parents who come into the system because of substance use issues, they're more likely to have allegations of child abuse and neglect be substantiated. They're more likely to have their children removed to foster care, and they are less likely than other caregivers to eventually be reunified with their families. Those are pretty devastating outcomes. This perfect storm, Ohio took the lead and started pursuing implementation of the START model. And I'm going to toss it over to Jennifer from PCSAO to tell us a little more about the model and the initiative here in Ohio.
Thanks, Alicia. So the START model, the Sobriety Treatment and Recovery Teams model, is a national model, and it has some key components here listed out. I'm going to highlight a few, and then we'll talk about some of the others during the Ohio START timeline, which will be our next slide. So one of the things that makes this a little unique is that it's a program administered within child welfare where both child health treatment and parental substance abuse is tied hand in hand. And so really we're looking at early identification of these families affected by substance abuse at screening level, where we're administering the an UNCOPE screening, where we're identifying substance use disorder, and then we're also administering the ACEs for the adults and the CTAC for the children around trauma. And then we're looking at the quick access to treatment. We'll talk a little bit more about that piece in the time frame. But one of the pieces that really makes the Ohio START model unique is that they are pairing the child welfare caseworker with a family peer mentor, and that family peer mentor has lived experience in child welfare and substance use disorder, and they are in long-term recovery, and so they're hired and paired with that caseworker to work with the family in very small caseloads of no more than 12. And for anybody that's ever worked in child welfare, especially on an intake level where you might have, 30 to 40, 50 cases, and then, 20 to 25 cases on an ongoing level, 12 is a really small caseload. So we're giving that, as it says in the next piece, that very focus and family-centered service to parent-child relationships. We're able to focus on a great deal more than the typical child welfare case. And then on number 5, they're increasing oversight for parents and children. We're meeting much more often with these families, which we'll talk about in the timeline. We're also holding additional family team meetings and shared decision-making meetings where we're really engaging the parents, the families, their sober support, and all treatment providers, and supporting the family towards recovery. And then through sharing responsibility for the parent accountability program outcomes, that is really follows through and comes out through direct line meetings. That is a structure that's put in place with the START model, where we're meeting with the service providers, doing a bit of case review, but a little bit more in depth than that. And then we're collaborating across all of our systems and with the courts. And this is often done through steering committee meetings that are held initially on a monthly basis, and they're really there from the ground level, being invested in START. And so that's a little bit about START, and then, as I said, we'll go into the time frame a little bit more. Next slide. So here, when we were talking about the early identification, we're really trying to get these, as all the data shows, that as soon as a family or a parent is referred for treatment, the quicker that they're referred, the greater the success and the outcomes. And so we're looking at getting these cases from the time of intake through the child welfare screening process into start within 14 days. And that really is a standard requirement with Fidelity that we're doing within 14 days to ensure that we have this quick turnaround and access to services. And then we're also, once they're referred into services, we're having what's called a shared decision meeting, or the SDMM that you see there on the chart. And that's really live in the field, you know, maybe in their home, maybe in a hospital. We're meeting them wherever they're at in the community, and we're having a meeting with them and any of their family members, any maybe current treatment providers that are involved in the case, to really make a plan for child safety, make a plan for you know, what their substance use looks like with treatment, and then turning that around in a time frame within a day of that. We're looking at getting them in for their SUD and mental health assessment, and then getting within 3 days of the treatment referral. We're moving into our first 5 appointments. So that includes that initial assessment and the 4 follow-up appointments for the SUD treatment, all in that first 12 days. So it is a really tight timeline. We do a lot of things to ensure fidelity is met, which I'm more than happy to talk about later. But that's just a little bit about the START program, the timeline, the quick timeline, to really ensure that services we're getting them in there initially from the beginning for those better outcomes for recovery. And then in the next slide, it just shows the Ohio START cohorts. There we go, next slide. So Ohio START is an affiliate of the National START model, as I said. And the National START model is a promising practice that's on the California Clearinghouse. And we are working on getting it approved for family first prevention or as a preventative risk. And Ohio first implemented the model back in April 2017 with cohort 1. And that was really that southeastern part of Ohio, where Alicia had given the information previously about how hard Ohio was hit with opioids, and particularly the southern and the southeast regions of Ohio were one of the hardest hit areas. And they also had very few services in those counties and really lacked support. And so Ohio START really targeted in on that population first because they were in such great need of this additional support, particularly through the Child Welfare Agency. And then in time, we grew to our cohort 2 in October of 2018. And then we actually added a cohort 3 last fall. And then we hope to add on a cohort 4 early next spring. So that's just a little bit of an overview of the Ohio START program and model. If you notice, there is one little bit different there. It says sobriety treatment and reducing trauma for Ohio START. We started the National START model. We just put a little bit more focus on trauma, and that's why we use the trauma tools, the ACEs and the CTAC that I mentioned previously. And so that's the only differentiation there with the name. But we are an affiliate of the Ohio or the National START model. All right, back to you, Alicia.
Thanks, Jennifer. All right, so as Jennifer explained, the START model is really about expediting access to substance use treatment for caregivers coming into the child welfare system. And before START began, before START started, it was not uncommon to hear about 6-month waiting times for parents to try to access treatment. And we place a really heavy emphasis on these timelines because according to federal legislative mandates for child welfare practice, when a family comes into child welfare custody and if children are removed to foster care, caregivers have about 12 months to work on their case plan before a judge determines whether or not the children whether the safety risks have been mitigated and kids can be reunified with their parents, or whether they haven't and might need to move to terminate parental rights. And so if you have a 6-month waiting list or a 6-month waiting period for treatment, you've eaten up about half of your 12 months of work in your case plan. And we know that reaching sobriety or improving substance use treatment outcomes can take a while. So that's why there is such a heavy emphasis on quick access to treatment and really tightening up that pipeline to make sure that folks get into treatment, get services, and start to improve their outcomes. So to be able to implement this model, there's a really heavy emphasis on collaboration. As you might imagine, to be able to work through, strong service demands for behavioral health treatment. In some of these communities that are rural and Appalachian, there may be fewer treatment providers. It really requires a very tight partnership between the child welfare system and substance use treatment providers in the community. So to be able to implement this model and at least get it off the ground, child welfare agencies, they need to identify a substance use treatment provider. They need to be able to negotiate with each other how they're going to deliver services. They need to figure out how they're going to establish communication channels about individual cases. And there is intensive case level coordination. On top of it, the family peer mentor is such an important component of this model. And for many family peer mentors with lived experience working toward recovery and even lived experience in the child welfare system, many of them are ineligible for employment in county government agencies. If you have any kind of criminal justice history, you might not be able to qualify for employment at a public agency. And so there's been a lot of collaboration with substance use treatment providers about bringing somebody on board. And if they can't be hired on the child welfare side, if they can be hired on the substance use treatment side. So there are a lot of more administrative and executive level collaboration issues that need to be ironed out in order to begin implementing the START model. And so these collaboration issues, they're really key for implementation, but the way that they look in our counties really varies. And it was something that we started observing with the first cohort. So another important thing about the context here in Ohio is that our child welfare, and for that matter, pretty much all of our service delivery systems are county-based. We have a very strong tradition of home rule, and responsibility for administering and delivering services is often devolved to the county level. There is some state supervision, but it's really at the county level where we see variations in the way that systems are structured, and in the past, they were financed really at this local level as well. In a lot of the communities that we're working in that are rural, there are also unique service delivery and collaboration challenges there as well. There might be a lower density of treatment providers. There's a different type of competition for limited resources. And there might be we know that there are inequities between urban and rural areas as well. So as we started implementing in cohort 2, our partners from the Ohio Association of County Behavioral Health Authorities said, these collaboration issues, we might be able to provide some help to counties if child welfare agencies connected a little bit more closely with the county or the regional behavioral health board. Before, when I mentioned that Ohio has a strong tradition of home rule, I wasn't kidding. It extends to the behavioral health systems too. And we have local behavioral health boards. We have 53 of them. And sort of the map is on the lower left corner here. We have 53 behavioral health boards, and many of our counties have tax levies that generate a set aside for behavioral health services, and as few as, I guess, maybe that was 7 years ago or so, Medicaid funding for behavioral health services used to be administered by these boards. It has since been elevated, but these county or these regional behavioral health boards still have a lot of power. They still have a lot of control over local funds, especially if there's a levy. They also have legislated responsibilities at the state level for coordinating regional opiate response. So these centralized administrative entities, they serve the public health function in our behavioral health world. And as our partners pointed out, they might be able to help child welfare systems connect better with substance use treatment providers and help expedite sort of the initial negotiations and collaborations because they manage these local networks of behavioral health providers. So our study was inspired by this potential here. And so our first aim is intended to examine these behavioral health boards, their efforts to align systems for START. Our study is intended to focus on cohort 2 of START only, and I'll explain a little bit more about that in a second. So we want to understand how they're engaged in START, or at least systems alignment for START, whether their engagement in systems alignment varies at the county level, whether there are some patterns in terms of the contextual features that might determine what they're doing to help align systems, and then ultimately what effect this is having on the timing, the strength of the partnership between child welfare systems and substance use treatment providers, and ultimately fidelity to that START model. And so we're conducting a mixed methods multiple case study. We are focusing, our initial intent was to focus on just cohort 2. There are 15 counties there. And last year at this time when we did our research in progress webinar, we had just submitted our IRB protocol. And so we got started with recruitment and data collection in December. And then, we got shut down in March and we paused a little bit and we re-upped again just back in July. And so after our very tumultuous year, we're very excited. We've gotten 9 counties to sign on board so far. And we've collected quite a bit of data from those folks. We're doing interviews, we're doing an analysis of contracts and MOUs and other formal partnership agreements. We have worker surveys that are in the field. They're actually going out tomorrow. I thought they'd be out today, but tomorrow, which is pretty awesome. And we're doing ongoing program fidelity data collection. So we're focusing on cohort 2. So these results that we're sharing today are very, very preliminary. We still have a lot more data to collect and rigorous analysis ahead of us over the next couple months. So in general, I also want to mention a couple months after our Systems for Action project got started, we were also funded by the National Institute on Drug Abuse for a separate study that focused on cohort 1. And as that study started up, we're also doing some qualitative data collection in about 9 counties in cohort 1. And so we were like, you know what, maybe we should ask about these behavioral health boards in those counties too, just in case. And that was, thinking back now, I'm like, wow, I'm really glad we did that because there was a pandemic that delayed us for a little bit. So some of our results today are drawing on the data that we've collected from both of those studies, from both of those cohorts. With, of course, please understand that there's a lot more analysis to come. So our aim 1 was focused on how are these ADAM-H boards, and ADAM stands for alcohol, drug, and mental health. In some regions they're called mental health recovery or substance use recovery boards or behavioral health boards. And so our first aim was, how are they engaged? What are some of the activities and strategies that they're using? And so in general, we heard that there is this level of general support and coordination that they provide to behavioral health services that is generally supportive of the Ohio START implementation. And so we mapped some of these strategies onto a common typology of public health, sort of public health activities. So generally we heard a lot about local assessment activities, that they identified unmet need, they identify what services are available, they help generate community support for behavioral health care, particularly in those communities that have to pass a tax levy on the general ballot every few Novembers. There's a lot of efforts dedicated to assurance, like disseminating information about what services are available, helping connect clients with particular services. We heard an example about how in one county they developed a centralized referral body. This happened to be in a county where there was a very robust behavioral health system, lots of different providers. We heard about how they legitimate or they vet providers and their quality before they're allowed, quote unquote, to be in the network. They provide funding for programs, particularly in counties with those levies. They also help generate or build service availability in more rural counties where there may be fewer providers, and so they may reach out to providers in other counties to see if they can maybe help expand their service programming into those regions. They provide training. We even heard a little bit about more active strategies like developing a standard release form or developing a standard referral form. So these general sort of system coordination efforts that are targeted toward the behavioral health system, they're not START specific, but we're hearing about how because there is this infrastructure there, it has helped facilitate implementation of START. We asked about more START-specific activities, and here's where we really heard a little bit more inconsistency. We heard that only 4 counties in cohort 2 were able to point to specific ways that their behavioral health board were engaged in START, and only 3 counties in cohort 1. And most of the time when these boards are involved in START, it's on a more passive on a more passive level. And so they may be engaged in the steering committee that Jennifer mentioned. They're sharing general information. In more limited ways, they're helping to connect or help identify a substance use treatment partner for a child welfare agency. And in some ways, we heard in one case that they're also providing some matching funding for another grant. So, but for the most part, this sort of START-specific engagement is a little bit more limited, which points to the potential for the ADAMH board's role to be expanded, especially as we're thinking about supporting cohort 3 and bringing on a cohort 4 for START implementation. A lot of our stakeholders on the child welfare side were not really sure how they would even engage the ADAMH board. So I think that there's some support there that we can provide for thinking strategically about how to engage and what to ask for from other stakeholders in the system. Our next steps here, we have a lot more data to collect, as I mentioned. Sorry, I need to turn off my texts. Our goal here is to create some sort of typology, drawing on, of course, some of the basic public health activities and frameworks out there, and also drawing on network management strategies and typologies that we see in the network administration literature as well. We're also, just a note, we're also hearing about some other sort of third parties like these behavioral health boards that also serve these functions, like Family and Children First Councils and family drug courts. So our progress, hopefully by the next time we get to check in with you about this study, we'll have a more firmed up typology of behavioral health board engagement strategies. So with that, I'm going to turn it over to Amanda, who's going to tell us a little bit more about what we're hearing related to AIM-2.
Okay, thanks, Alicia. So turning now to AIM-2, what we're looking at here is our county context and how boards involvement varies across county. So you've heard several times already in this presentation about the decentralized model we have in Ohio. We are drawing on collaborative governance frameworks and certainly prior literature on interorganizational relationships to see how boards may be involved and how their involvement may vary based on the system context. Okay, next slide, Alicia. So in terms of system context, what we're talking about are issues like provider density, demographics of the county, county needs, the extent to which the intensity with which they're struggling with the opiate crisis, and collaboration history in the county. And so some of the things that we have been hearing so far in our interviews is that first, provider density is an issue. The number of providers really matters. When there are multiple providers, that can increase challenges for child welfare to manage. Similarly, if there aren't enough providers, right, that limits options both for the county in terms of partnerships as well as families. One phenomenon that we've heard quite a bit about is the influx of substance use disorder treatment providers entering the market. So counties are experiencing pretty significant increase, particularly in private providers, but also nonprofit providers, capitalizing on the needs in the counties. And as Alicia had mentioned, this is one of the roles that the board plays. In part is vetting, in some cases, some of these new providers. Certainly balancing needs for preferred providers with client choice is a real challenge. So as the person on the team that studies contracts and formal partnerships, what we've observed is that counties will put preferred provider contracts in place, which aligns with START program objectives, but clients have choice and can choose alternative providers or even providers in different counties. And so adhering essentially to those partnerships can be a challenge. Counties that have ADAMH engagement tend to, on average, have more providers in the county than those without. The second issue that we are hearing is this history of relationships with the board. So this could be either positive or it could be more strained. So in some cases, we have very strong ADAMH engagement. Others, we are hearing that there's these strained relationships which may in fact impede some dimensions of collaboration. And consistent issue in social services generally is turnover. So we see turnover in family peer mentors, in frontline workers. Burnout can certainly play a role in those two factors, as well as leadership in the organizations at the board level, as well as senior leadership in child welfare. Next slide, Alicia. So what's next? We're still collecting data, as Alicia mentioned, but we will move to begin to analyze that data. Our approach is a multiple case study where each county is its own separate case. And this will help us to examine the engagement intensity given these contextual conditions within each county and then across counties. Okay, Alicia, I think I'm back to you.
Awesome. All right. Thanks, Amanda. So our third aim, our first aim was about understanding how boards are engaged. Our second aim was understanding whether that engagement varies by county context. And our third aim focuses on, does this make any difference for how well or how intensively or how quickly child welfare and substance use treatment partners are able to establish that collaborative partnership for START implementation? And yeah, so ultimately, we think that such strong collaboration and quick collaboration will lead to better fidelity to the START model, as indicated by the number of days or the timeliness of being able to connect parents to treatment, and ultimately to client outcomes like child safety, child's permanency, and parent recovery. So that's our conceptual model. For this, we're starting to draw on agency documents, and Amanda is leading us in a really in-depth, super cool analysis of memorandums of understanding and contracts. It's super fascinating. We're also drawing on worker surveys that are in the field that measure collaboration strength, referral partners, the frequency of referrals, and we're also drawing on case level information to measure fidelity to the model at the county level. We're drawing on the OSU Needs Portal, which is a separate system that was developed for child welfare practice generally, actually in LA County, California, and then brought here to Ohio by Bridget Freisteller and adapted for the Ohio START initiative. And we're looking at the number of days between referral to START and screening, the average number of days it takes from the beginning of that case to that first family peer mentor meeting, and the average numbers of days between beginning the program and then actually receiving their first treatment. And so we're still in the process of gathering a lot of these data. So I just want to share a little bit of what we're seeing so far in some of these constructs and measures. I'm going to turn it back over to Amanda real quick to talk about what we're seeing in the analysis of contracts.
Oh, sure. So, and that's kind of you to talk about the analysis being super interesting. We might be the only people that geek out on contracts, Alicia, but this is really interesting look at cohort 2's contracts. So what you'll see here in this busy table is that we have most of the contracts are MOUs. We have a few different other types, but generally speaking, the counties are entering into MOUs. Disappointing from my vantage is that only 2 of the contracts engage or have a role for ADAM-H. That doesn't mean that the ADAMS boards are not engaged in START. It just means that they're not identified with a role in the contract. In the 2 contracts that you see here, their role is essentially facilitating funding for the 2 counties that are identified here. We have a variety, as you can see here, of different types of contracts. So whether the services are for more strictly mental or behavioral health or substance use disorder. A number of contracts that were utilized in cohort 2 in one county in particular were leveraging their drug court contracts for implementation. Family peer mentors, that service is also one that is fairly commonly utilized and a key feature of Ohio START. We also have a number of contracts in counties for, that are fairly, we call these other because they're, dealing with PHI or other types of confidential information, or it might just simply be an intent to collaborate. Most of these contracts in cohort 2 are related to START and were implemented in conjunction with START. Okay, County A, as you can see, has a number of contracts that are not related to START. Just for a bit of comparison to cohort 1, that number is much lower. Their number of formal partnerships in terms of certainly a percentage of their overall contracts is lower on that START specificity, if you will. Okay, Alicia.
Great, thanks, Amanda. So there's a lot of nuance in those contract documents, and one of our goals is to really identify, we certainly have plans for them in analysis, but on a practice level, we also want to be able to provide some recommendations for contract components or sample language that other counties might be able to draw from and help expedite their collaboration process and their contract process when it's their turn to implement START in their counties. In terms of fidelity, this is a really important sort of dependent variable metric for us in our AIM-3. We're drawing on information from the Ohio START dashboard, and this is something that's managed by Bridget Freisteller and her team at our College of Social Work at Ohio State University. There's the website there if you want to click on it. I don't know if you can click on it from your screen, but super cool way of sharing in almost real time with our stakeholders leaders around the state and beyond how we're doing with Ohio Start. We're drawing on that information to create our Fidelity Metrics. And so some of our preliminary results, we're still working on gathering data about treatment dates for substance use disorder treatment, but we were able to take a look at the number of days it takes to do the screening, the number of days until the first family peer mentor visit. So these are two very important milestones in that timeline. And so on average in cohort 2, or I think actually the results I'm going to share are across cohorts 1 and 2, just to give us a little bit more power there because we've got 18 counties to play with. But across these 2 cohorts, these 18 counties, we're getting these uncoped screenings done in about 4 days, and we're getting parents connected with a family peer mentor visit within about 17 days, which is super fast, and that's great to hear. But there's certainly variation across the counties. And so based on these 2 metrics, we were able to categorize counties into one of 4 groups. So the first group is those that are doing above average in terms of getting the substance use screening done, and those that are above average in getting the family peer mentor visit on the books. So then we've got a subset of counties that are doing a great job at screening, but may take a little bit longer to get that family peer mentor visit. So, you know, these counties in this second group here, they do the uncope like almost immediately, but it takes them about 55 days to get the family peer mentor visit. So all of these metrics sort of represent variation in that fidelity to the START model, and could be directly determined by, you know, how well they're working with their substance use treatment partner, especially if the substance use treatment partner is hiring the family peer mentor. So we see these as a result of collaboration in part. Then we've got a subset of counties that take a little bit longer than normal to get their screening in, but are able to get the family peer mentor visit in pretty quick. And then we've got a subset of counties that are struggling along both dimensions. So we categorized our counties into these 4 groups. And then we started to take a look just at how they varied from each other. Are there any patterns that are starting to emerge? So among these counties, we've got 5 counties that are doing pretty great at both the screening and the family peer mentors. They're likely to be in cohort 2. They're likely to be rural. They have a moderate number of behavioral health treatment providers in county, and they're not likely to engage in the Adam board, which sort of does not support what we were hoping to find in this study, which is interesting. Our second 2 groups, where they're doing great on one dimension and are still working on tightening their timeline on the second dimension, they look kind of similar. You know, they're kind of evenly split across cohorts. They're equally likely to be rural or urban. They both have about, you know, moderate numbers of substance use treatment providers in county. And the ones that take a little bit longer to get their family peer mentor visit, they have some ADAM-H board engagement. Those that get a quick family peer mentor are very unlikely to have ADAM-H board engagement. Then our 4th group, these are the counties that are struggling on both. They're likely to be in cohort 2. They're likely to be urban. They tend to have more behavioral health providers in county, and they are likely to engage with their ADAM board. So this really flies in the face of what we thought we might find. And so we're starting to think more about this. We've got much more rigorous analysis planned. We're planning to use qualitative comparative analysis, which integrates both quantitative and qualitative data. It's based on Boolean algebra that generates sort of pathways to an outcome, recognizing that there are lots of different ways to collaborate and implement effectively, but maybe there are patterns in what that looks like. So that's our plan moving forward. So just to sum up real quick, we have a lot of data and we're still in the process of collecting it, but we think, you know, we're trying to think about like, what does all of this mean so far? So generally, we think that what we're seeing is that there's limited ADAM-H board engagement in START specifically. It's primarily passive engagement, but generally, these boards are recognized as a major funder and a major influence within the behavioral health systems across the different counties. We're thinking that perhaps these boards, they cultivate the system environment and the collaboration norms. although there's a lot of potential for these boards to help support system alignment, particularly for START, a lot of our child welfare stakeholders are really unclear about some of the strategic benefits that would be derived from engaging them specifically. So that might be a path forward for us. ADAM-H board engagement, they tend to be more engaged in system alignment where there are more providers and more urban communities, which may point to the fact that these boards have more of a role and more to do and more of a challenge in some of these more complex counties and environments. And that system alignment and the implementation of models like START that really depend on this kind of tight collaboration might be uniquely challenging in communities where there are lots of providers. And this might be where strategic ADAM-H or other type of third-party coordinating entities, engaging them might be really useful in these counties. So again, I think the overall picture here is showing that system alignment and implementation looks very different depending upon the context. I think we would be remiss in not acknowledging the impact of COVID-19 on our project and on the program. As I mentioned, most immediately, it affected our data collection timeline. We paused for about 4 months with data collection to give our partners on both the behavioral health and the child welfare side some time to adjust and plan. There was a lot of uncertainty. There was a lot of panic among all of us, really. And so we felt very strongly that we did not want to add any additional burden to anybody else's life or work during this time. So we paused. We picked up back in July and we started asking folks during our interviews just generally about how the pandemic has impacted services in general and the START model and collaboration specifically. What we're hearing generally and when we're here talking with our partners in the field and in our project, we're hearing about increases in relapse and overdose, particularly among those with opioid use issues. We're hearing about increases in suicide risks. And at the same time, we saw a decrease in maltreatment reports to child welfare services, predominantly because kids were back at home and not in school on a daily basis, and less likely to interact with folks like doctors and mental health providers who are mandated reporters. There's an anticipated shift in these service demands as kids go back to school. So, it's really echoing what we're hearing on a national level about increased mental health and substance use treatment needs as a result of the pandemic. In terms of service delivery, both the child welfare and the behavioral health side transitioned very rapidly. I was so impressed with sort of the strategy and quickness with which a lot of our providers across both of these systems were able to transition to a telehealth environment to deliver services. There's also a lot of really creative service delivery going on, an opportunity to meet with kids or families, on the front porch or at a park, and still be able to have a face-to-face visit, but still do it taking precautions with masks and social distancing. However, this comes with some downsides too. Our behavioral health providers are a little concerned about virtual group attendance. Social distancing has sort of really hampered groups like AA and NA from meeting. These are in-person groups. And we've heard from some providers that host these groups that they're not able to continue to have them because they don't feel comfortable. They have a certain number of people that they can let into the building for these kinds of groups and still maintain social distancing. But we're concerned that, if somebody shows up in need, they don't want to have to turn them away because they've surpassed the occupancy that they're allowed during these times. So these are some serious challenges. So telehealth is great, but it's not the end all be all. There's still really value in face-to-face services. And I think that there's going to be a long-term impact of constraining in-person treatments and services. On the behavioral health side, our Ohio Medicaid program was able to shift and allow providers to bill for telehealth services, but these visits tend to be shorter than in-person treatment, so providers get reimbursed at a lower rate for them. And so there is some serious concerns about financial viability. These are predominantly nonprofit organizations with thin margins in terms of their revenue. Many of them had less than 1 month's cash on hand, and were not able immediately or very quickly to be able to access things like PPP loans. So they're seeing about 20% losses in revenues, although they've been able to get some CARES Act funding to sort of offset those losses, at least through the end of the calendar year. So we've got a lot of observation to do, and hopefully we'll be able to help in some ways as we move forward. Our plans as we continue our analysis and knit these data together, we are planning on creating a toolkit that includes just a 2-page brief describing results. These are things that we worked very closely with PCSAO at the outset to sort of think about, what would be some practical products to result from this work. We're going to generate some specific examples of how to engage a board in START implementation and generate some recommendations for when to engage a board, how to engage a board. And we're thinking that some of these rural-urban differences might be informative for them. As I mentioned before, we also have a NIDA funded R34 with our cohort 1 counties, and we're creating a decision support guide there that's focused more on collaboration between child welfare and substance use treatment providers. It doesn't include this ADAMH component. As we move into that work, we're hoping to include this ADAMH piece as a module in that toolkit and to be able to test the feasibility of that as sort of the last component of that study. So we're really excited about the complementary nature of these 2 studies and to be able to continue on our S4A project trajectory and be able to sort of put some of these recommendations in the field and see how they're, what folks think of them. So we've got general references. We're very grateful for the community that the S4A program has created among its grantees and all the partners associated with these programs. It's really great to be part of a group of people who are similarly perplexed and impassioned by issues of collaboration and system alignment. It's a really wicked problem. An equally wicked problem is program implementation. And likewise, I'm very grateful for the community that's been created around these issues at the Society for Implementation Research and Collaboration. And so if you, like us, are grappling with collaboration issues, you found the S4A community. If you're looking for an implementation community, I'm very appreciative of CIRC. There's some contact information there for that group as well. And so now I'm going to pause. I think I've talked way too much. Yeah, I have. And I'm going to turn it over to Jennifer from PCSAO to talk a little bit more about her reactions to some of these findings and questions for us moving forward.
Thanks, Alicia. I just want to address, somebody had asked a question in the Q&A. There was one question about the why are acronyms different for the national program versus the Ohio program, which is a national affiliate. And I responded, I just want to let everyone know that the Ohio START want to focus more on the trauma that is often the underlying issue in regards to SUD. And that's why we've also added the ACEs and the CTAC screening for trauma for both the adults and the children. So the model is the same, just really wanted to put more of an emphasis and a focus on the underlying trauma, which often is precipitates the SUD. And then we had one other question. It said, do the behavioral health boards deal with dementia and depression in the elderly and their caregivers? Is there anything like START available to older adults with substance use problems? So local mental health boards do often, depending on the age, sometimes you might be able to get more resources through the Council on Aging, for local Council on Aging, but mental health boards would be able to direct you to that also. And then START available to older adults with SUD. So START is specific for child welfare only and child welfare cases that come into the county. So if those older adults, because we do have a variety of adults that we serve, there's no age cap. It's just whether or not they have children that are under the age of 18. So if there's anything specific to that, because that's so unique to peer mentor, there are programs through different SUD and it really varies everywhere, but there are different SUD programs that do partner family peer mentors or peer supports, they're called. They work in the SUD arena. They also work in the mental health arena that they often will pair them up with. So there are different types of programs out there like that, but it would really just depend on your jurisdiction and where you live. So we're getting some more questions in here. I will jump in and say a few things before I answer the next question about START, is that, so, you know, Ohio has 88 counties, and the ongoing joke is that we have 88 different ways of doing things. So, you know, I think about when you talk about the maybe not seeing as much engagement there as possible, I think there are a lot of different factors that play into that. Some counties have their own individual boards. Sometimes there are regional Adams boards where multiple counties are in that region for that one mental health board. And so that often, especially when you're looking at child welfare, will play into that factor, because you might have 3 or 4 counties in one region. Each of those counties has their own child welfare agency and run it their way with our state oversight. So you've got this individual nuances, but then you've got this one regional board. So then really you're looking at 5 different dynamics at play there. So that's one of the thoughts that came to mind when we were talking about the Adams boards. And then also the levies do play a huge part in that and really determine that level of engagement, that level of funding opportunities that the counties are able, the Adams board are able to work with child welfare agencies or other behavioral health providers. And then you had mentioned also that the first thing that came to mind when we first started talking about that was family first councils too, and how sometimes family first councils in counties play a kind of a bigger role than maybe Adams boards do in regards to child welfare. So that dynamic is very different there also. Another thought I had, Alicia, was as you guys continue to do this work is in regards to Adams board and partnerships, like really think about steering committees. It'd be interesting, even though they might not have, you know, we only have a couple of counties that had MOUs with their Adams boards, but how many of our counties have Adams boards on their steering committee? I think that would be an interesting piece to look at also. When I was in Hamilton County and implemented START there on the child welfare level, you know, we met with our local Adams board immediately, and even though we don't have an MOU with them, we were very engaged with them. We saw them as a primary stakeholder in the community. We had meetings with them initially on an ongoing basis. You know, that then leads to within Adams board subcommittees that they might have with SUD. So that's another piece that kind of plays into that is really what a partnership looks like, and you know, are we actively engaging them through a steering committee meeting or bringing them on as an initial community stakeholder when implementing START in the county. So yeah, so those were some of my kind of initial thoughts. We were going through the slides, and then we've got one question here. Do you have counties that collaborate with police agencies and utilize their front row seat within the communities in order to make referrals to START? Police officers respond to many calls and or interactions that could be great referral sources to START. Yeah, so actually there was just a recent law in Ohio passed. Previously, police were not mandated reporters for child welfare. They are now mandated reporters. And so if they go out into the field and they come across a case that involves a parent and a child is with them, they often do, you know, they're required to call that into our hotline. You know, every county has a hotline for child abuse and neglect, and so they do call that in and make a referral. And so that call has to be made to child welfare, and we have to accept that referral into the child welfare system in order for them to work with START. The START program is really embedded within each individual county child welfare agency. So as long as a call is being made to an individual county child welfare agency and that report is taken on the intake level and it's screened in and it becomes an active case, then there is that possibility to make a START case. All right. So Alicia, any other questions or thoughts or questions back to my thoughts about, you know, just things that I found interesting about next steps, particularly the steering committee and Adams board partnership, I think would be a fantastic thing to consider.
I love that idea. And especially as we start to make these county level sort of case studies, I think those are definitely things that we should look at and account for in the analysis. Oh, I love these conversations.
And if there's no other questions, just one thing I wanted to say too, Alicia, is, you know, another time we can talk about, you had mentioned counties that have, through the Adams board, a central process for behavioral intake. I sat and worked with 2 different counties, one of them having that method at one time and then reverting back to not having it centralized through their Adams board. So I think there's a lot of interesting ideas there too. You want to discuss that more off time?
That's a good idea. Yeah.
All right, everyone, join me in thanking Drs. Alicia Bunger and Amanda Girth and Jennifer Millizer for sharing such interesting updates on their study. If you are with us for educational, excuse me, and you would like to receive a certificate of completion for today's ResProg webinar, please complete the survey at the end of the session. One will also be emailed to you. And if you're interested in learning more about our projects and seeing other research in progress webinars, we archive them on our website, systemsforaction.org, along with any publications from those studies. Our next webinar will be October 14th, same place, same time. We'll be hearing from Benefits Data Trust, and we also have one coming up October 28th. We'll be hearing from Los Angeles County Department of Public Health. Thank you again for joining us, and we look forward to coming together with you in October. Have a good day.